Hi, it is a great honor to be invited to participate in the Sarawak Pediatric Surgical Update held at the local hospital. My first topic is on pediatric stone disease, which I will illustrate with real cases from my fellow pediatric nephrologists, pediatric surgeons, and the other nurses of the team. Urinary stones can occur in any part of the urinary tract. It can be in the kidneys, the ureters, the bladders, and even in the kidneys. It can be in the lower calyx, middle calyx, superior calyx, anterior and posterior, and down in the bladder, the stones can get stuck in the urethra, and especially in the male patients. In developing countries, we have a condition called the primary bladder stones, which is common in children, and the stones occur for no secondary reason. What are the local data in Malaysia? When I was working in the General Hospital in Kuala Lumpur, I looked at the 5 years cases of pediatric stones, with the majority of them being managed by myself. And these stones were in the kidney, in the ureter, in the bladder, and urethra. Note that there's a big percentage of stones in the bladder, and this is the patient with the stone in urethra, which I remember very fondly because I was busy and the local pediatrician helped me to catheterize, and of course they failed to catheterize, and the patient had a suprapubic catheter inserted. From that study, we find that patients may have stones due to metabolic reasons, due to underlying anatomical reasons, and sometimes due to chronic urinary tract infection. But even in children, a huge proportion, 65% of them, we could not find a definite secondary cause, which means that they have got what is called idiopathic stone formation. What about in Sarawak, where we are having the workshop now? A study funded by the National Kidney Foundation, conducted by Dr. Kamaraj, found that stones occur in 5%, 4%, 4 to 5% of the population, in equal proportions between male and female, and usually in the younger patients. But this group did not include any pediatric patients. Worldwide, there's increase in stones, possibly due to the global warming effect. And according to a study done in Taiwan, the ratio of male to female is 5 to 1. In the general surgical practice, urology is 30%, and of these 30% are due to stones. So in most countries, the urologists tend to manage more of these stone disease rather than pediatric surgeons. In the Western hospitalization data, there's 1 case per 1,000 to 7,006 admissions. In Europe, the incidence of stones in children is 1 to 2 per million population, and it occurs equally in male and female. I did the email census of my colleagues in Asia Pacific in 2017, and I got a reply from my friend in Taipei. Of course, Taiwan is considered a developed country, and he said he doesn't have a lot of pediatric stone disease, but it's probably prevalent in other Asian hot climate, including Indonesia, Pakistan, and India. And indeed, when I look at the publication from Iran, they have got 1% of school children with stone disease. What about the symptoms of these children with stone disease? According to a presentation from Indonesia, when they came to Kuala Lumpur for the Asia Pacific Asian Society of Pediatric Urologists in 2016, patients with stone disease often have non-specific symptoms like uncomfortable voiding, fever, some urinary retention, abdominal pain, or a combination of these symptoms. Of course, we need to do some kind of investigation for most patients with any condition now. Of course, for stone disease, it's important to have urinalysis, and almost all of them will have microhematuria. Imaging in children usually consists of ultrasounds and occasional x-rays, and very, very occasionally a low-dose CT urography. Blood tests, of course, includes kidney function, checking the calcium, uric acid, full blood count, and sometimes we also do a 24-hour urine for recurrent stone formers in children. The commonest investigation used in pediatrics for stone disease is ultrasound, looking for hydronephrosis, following the hydroureter to see the stone, and if possible, to follow the ureter. And usually at the bladder, we can see the uretrovesical junction. Now, of course, if there's a big stone in the bladder, you can easily see it on ultrasound. The standard of care for stone disease nowadays is that of CT scan, where you can see a stone very well, see the entire ureter well, but it has to be low dose in children. We don't use contrast, and of course, there's a cost which is more expensive than ultrasound and plain X-rays. The CT scan should be low dose to reduce radiation. We should know the size of the stone, the anatomy of the stone, how hard is the stone, the distance between the skin to the stone, and as I said earlier, emphasized earlier, it has to be a special low dose CT scan. What are types of stones? Most of the stones are calcium stones. And in Asia, we have a lot of uric acid stones, especially during the fasting month. About 20% of patients coming with stones may be radiolucent. And of course, we have the infection stones and we have the congenital stones. These are stones that we removed many years ago, maybe 20 years ago, when we do a lot of open surgery. We must try to stand the stone for analysis, but quite often in many public hospitals, the stones will come back as positive for almost everything: calcium, oxalate, phosphate. In some hospitals, like the University Hospital, they have a special project whereby they can look at stones at a special cost, which is economical for the patient. Now, we look at how stones are managed in different parts of the world. This is a publication by Dr. Simon Chung, who is a Malaysian but now working in London. And the range of stones and the treatment is as follows. 91% of them had ESWL, and some stones had ureteroscopy, some have PCNL or PCNL plus shockwave, extracorporeal shockwave lithotripsy, and a few stones had open surgery. Note that they have no stones in the bladder. So this is a slightly different pattern of stones in developing countries. This is taken from my colleague who worked in the East Coast in Hospital University Science Malaysia. These are the procedures he has done, including heminephrectomy, open surgery for stones, endoscopic surgery for stones, endoscopic surgery for stones, percutaneous endoscopic surgery. We still use a lot of ureteroscopy. In fact, indeed, ureteroscopy is the commonest surgery both in adults and pediatrics for stone disease, PCNL, as well as ESWL. Now, this combination of slides is from my colleague, Dr. Tay and Dr. Alan Goh, whereby they show the different steps of surgery to remove a big bladder stone. And indeed, I think this is probably the commonest performed open stone surgery in pediatrics. If the patient has big stones or multiple stones, this is probably a better technique, fastest technique compared to transurethral, and the urethra may be narrow in children, and this can damage the urethra. Big stones in the bladder, in the ureter, and the kidney can also be managed laparoscopically instead of doing open surgery. So this is a report from China showing a percutaneous approach to remove bladder stone instead of using endoscopic means through the urethra. Again, this is a report by the same group at the Saiful Anwar Hospital in Indonesia, whereby they practice both open surgery as well as percutaneous surgery to remove the bladder stones. Extracorporeal shockwave lithotripsy is a major advance in the management of stone disease, and of course, it can be applied in pediatrics. But of course, in a child, there may be limitations if the child is too small, because the skin to stone distance has a fixed focus depending on the machine. And sometimes, of course, if the child is very small, we have to do the correct padding to protect the nearby organs, because the shockwave can also damage the kidneys. This is an old study from India, whereby they apply ESWL or extracorporeal shockwave lithotripsy to upper tract stones, renal and upper urethra, for stones that are less than 2 centimeters, whereby they apply shockwave to children, and they find that actually the success rate is as good as in adults, with a stone-free rate of 84%, not 100%, 84%. This must be explained to the patients. they find that the retreatment rate is 64%. And again, they are applying to patients. This is a study from Egypt where stones are less than 2 centimeters. I think these are quite old studies. I think with modern instruments, with smaller nephroscopes, I think stones which are more than 1 cm or 1.5 cm tend to be treated with PCNL. So this shows PCNL being performed. Is puncture the kidney to break up the stones. And of course, once you puncture the kidney, there's always the risk of severe bleeding, the risk of sepsis from fragmentation of the stones. We need to have smaller nephroscopes. And of course, this often involves radiation, irrigation, general anesthesia, and a big team of medical personnel to do the PCNL, which is, of course, can be quite costly. So this patient, this is the same patient who had ESWL for 2 small kidney stones, completely broken the stone. ESWL is also not harmless. It can cause bruising in this child. This is from an experimental study showing that the kidneys can also be bruised. And of course, in children, this has to be done under general anesthesia, safe general anesthesia in a proper ESWL suite. So the stones quickly recurred after 2 years. And the second time, the surgeon went in by a PCNL. Hopefully, this can clear the stones. Of course, prevention is very important. This is a big study from the International Society of Urology. They have got 96 centers, thousands of patients, but in actual fact, children is a very small proportion, and it shows that they have also used PCNL, but only in 13 patients, and they have come to the conclusion that the outcome, the surgical outcome for PCNL procedure in children and adults are comparable. If the stone is in the lower ureter, a success rate is good with a ureteroscopic approach, endoscopic approach, but then we still need to use suitable energy, in this case, using the laser to break up the stones through a small fiber. And of course, again, there's a significant cost from the laser, from the general anesthesia, from the hospitalization, and from the much smaller ureteroscopes. We mustn't forget that we can also apply medical therapy, medical expulsive therapy. We give the patient something to relax the bladder outlet, lower ureter, and usually in children, we use off-label an alpha blocker called terajosin. Ureteroscopy in children is safe, resulting in a good stone-free rate. And this is done on quite a big number of, this is a review on a big number of patients, 1,718 patients. This patient has ESWL to the kidney stones, ureteroscopy to the lower ureteric stones. So if you use a combination of modalities, which is also used in adults to the children, the results are as good. I was looking for some cases in neonates, in infants, and I got these pictures courtesy of Dr. Susan Wu in Kuala Lumpur, where they have a child with almost like giant ureteric stone. This patient had a big stone in this new infant had a big stone in the bladder because she has some underlying congenital abnormality. And this child is born with kidney stones and presenting with infection. So in very small children, the ureter is small, the urethra is small. So it's very important we do no harm. We do no harm. So endoscopic surgery through the urethra, up the ureter may not be the best thing. Maybe it's better to do open surgery or do laparoscopic surgery to remove the stone. Traditional treatment for stones in Asia is very popular. There are many things which can be used, but I think all of them come with increase of fluid intake, which may have some benefit to clear the stones. Another important thing is the idea of stone-free. For a long time, when the people say the treatment is stone-free, it doesn't mean they have no stones. It simply means that they have small stones or clinically insignificant residual stones of less than 4 millimeters. So if you have small residual stones, in children, it's likely they will become symptomatic or the stone will grow bigger. And of course, in children, it's difficult to do a study using CT scan to make sure that they are stone-free. So in children, it's extremely important we practice prevention of the stone disease. So dissolution therapy is important, prevention therapy is important, and dissolution therapy is effective in radiolucent stones. Radiolucent stones. In this study, they use it in 87 children, and over a period of months, many of the stones, 73% of the patients become stone free. So oral dissolution, you can use a nitrate, a citrate solution, alkaline citrate, either sodium or potassium citrate. Of course, we have to be careful with the potassium and the sodium. So in summary, ladies and gentlemen, pediatric stones can be treated with good success as in adults using very similar techniques. Medical therapy is important. Upper tract stones, less than 15 to 20, can be treated with shockwave, although we have to explain to the patient the success rate and the retreatment rate. Bigger stones can be treated previously by open surgery. Nowadays, it's by small or mini PCNL. Bear in mind that the patient can have serious morbidity and sometimes mortality from bleeding and sepsis. Lower ureteric stones can best be treated by ureteroscopy, but beware that we should not damage the ureter. Bladder stones can also be treated endoscopically, either transureteral or percutaneous, but if they are big multiple stones, especially in small children, small ureters, it may be better to treat with open surgery. It's important to follow them up to make sure that they are stone-free and not just having small residual stones, because they will become symptomatic again. Drinking adequate fluid is probably the best preventive measure. They have to do some diet modification using urinary alkalinizers, and of course to correct any underlying metabolic abnormalities like renal tubular acidosis, any stasis, poor bladder emptying. All these are important. So in summary, this is my last slide, ladies and gentlemen. Pediatric stones are prevalent in Malaysia. Presentation may be non-specific, just with UTIs, fever, poor health, hematuria, renal impairment, and diagnosis consists of doing urine tests, urine culture, ultrasounds, X-rays, and occasional CT scans. The management of stones depends on the local expertise and, of course, the socio-economic environment where they can purchase the smaller instruments, the lasers, and of course, ESWL are all very expensive. Thank you for your attention.